Newborn screening is about 50, probably actually 55 years old now. It kind of came out originally of treatment efforts in PKU in families who had one baby with PKU that was subsequently shown to be very severe, have the very severe phenotype. Those families could have their babies tested very early in subsequent pregnancies, and they can be identified before they started becoming symptomatic. The treatment of those individuals is very much as it was before any of the drugs that are now available for PKU, that is dietary restriction of phenylalanine, and it was eye-opening. Those babies treated early were as near as anyone could tell in very small N of 1 trials, completely normal, and that really led to a groundswell for trying to identify this disease early before brain damage occurred. About that same time, Bob Guthrie, one of really the father of modern newborn screening, had come up with a test that could be used relatively high throughput and implemented at a population basis for identifying PKU. So there were a couple of pilots done in Massachusetts and New York State. It worked. And over the course of about 10 years in the 1960s, newborn screening was implemented for PKU, was implemented in all of the states. Once that barrier was passed, the folks started thinking, well, maybe there are other things we could identify that would be helpful. And there were a handful of disorders that could similarly be identified in a relatively high throughput fashion. Early treatment made a big difference and got added to newborn screening programs. Up until about now, really the early 2000s, most states, in fact, screened for about a half a dozen disorders, and that was it. There was a paradigm shift in the first decade of the 21st century as folks realized that you could adapt the diagnostic technology that was used to identify a whole family of inborn errors of metabolism. You can identify about 50 different disorders with the technology called tandem mass spectrometry. So the use of that in newborn screening really just opened the field wide to expand by a lot. Such that by now about 2015 or so, now all of the states were using tandem mass spec to screen, and now we were able to identify those, depending on how you defined them, 30 or 40 or 50 disorders instead of just a handful of them. That was a huge deal. Many of those disorders were identified by babies who got sick and died in the newborn period, or had later onset symptoms and that couldn't be treated once the diagnoses were ascertained. I can give you a quick example. Fatty acid oxidation disorders are disorders where the body can't break down the stored fat that it needs to make fuel when you're fasting or you're under stress, like an illness. Many of those disorders presented as sudden death with no previous warning that the child was at all ill or had a condition. Some of them were obvious clinically in the first year or two of life, but because of damage that had already occurred and the lack of a therapy, about 70% of them would die by age 10. So bringing this to newborn screening, you eliminated those sudden unexpected deaths, and there was now the ability to start looking at these patients and keeping them healthy, and now especially for some of those disorders, there are treatments available. And for example, the long chain fatty acid oxidation disorders, where I was saying that the 70% died by age 10. Now they don't. They live to adulthood, and because that screening is only about 20 years old, our oldest patients are only about starting to hit 40, but it's, you know, they survive and they do well. The next generation beyond that now is really turning to molecular technology, looking at DNA sequencing to identify disorders, and eventually probably looking at techniques that can survey the entire genome and identify essentially anything that might affect a newborn, as opposed to just things where there were what was considered an easy test to implement in the early going. We're a ways away from that. There are pilot projects now to look at that, but it is something that we're probably going to see in the next, I would guess, 10 years is slow adoption of those molecular technologies into newborn screening as primary screens, as opposed to follow-up.